Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is brought to you by AACN's online course, Essentials of Critical Care Orientation, or ECHO, providing modular, interactive, case-based orientation for ICU or PCU patient care, with information available at www.aacn.org/orientationcc. Now here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. This is Andrea Schmidt, one of AACN's Clinical Practice Specialists. I'm joined by my colleague, Dr. Vicki Good, AACN's Chief Clinical Officer.
Welcome, everyone.
So nursing is one of those professions where you can't leave your heart at home or on a shelf in the break room before you start a shift. Compassion and empathy are both important components of that work. However, as we all know too well, the physical and emotional toll of caring for others can really be tremendous. Nurses need and want to take care of themselves, but sometimes it takes more than the nurse alone to preserve their well-being. Vicki, do you agree you've seen that?
Absolutely. And we also know from our research that the health of the work environment directly impacts the health of the nurse or the well-being of the healthcare worker. So I met today's guest, Kristi, at the National Academies of Medicine Action Collaboration on Clinician Wellbeing back, almost a year and a half ago, 2 years ago, and found her role to be fascinating. And we'll get into that in a little bit. But Kristi, I'd like for you to take a few minutes to introduce yourself to our audience.
Yeah, thank you, Vicki. And it was a great meeting you a year and a half ago, and to continue to partner with you in this work. So my name is Kristi McClure. I am a nurse. I've been a nurse for over 25 years. When I was working at the bedside, I was really working in labor and delivery, which probably for your listeners is a little different and outside their normal practice area. But I did that for about a decade, and then really kind of like transitioned into education. Taught at a local nursing college. I was a clinical educator for about 5 years. And then somehow I ended up in the quality department here at OhioHealth in Central Ohio. And it was really in the quality department that I sort of found my love and my niche and what I have absolutely become super passionate about doing, which is really doing work around well-being. That all came about because, the way that we take care of our patients, our quality outcomes, our patient safety events, all of that is directly tied to the well-being of the care team. So we were doing a really great study around that. I happen to be the clinical outcomes manager for critical care, which was totally outside my wheelhouse, right? And it was just a really great learning journey. And now I help to lead the well-being strategy and program development here at OhioHealth.
That's great. And you really have a unique job. Most systems have one well-being officer, and generally it's a physician. Mm-hmm. So how did you get into the health system well-being advisor?
Yeah. So like I said, in the quality department, they were actually doing a pilot study looking at burnout and well-being and how they could potentially do some tactics and some small bite-sized resilience techniques. And how would that change and improve our clinicians' well-being? And so in my role, my unit, one of the units that I supported, which was our MICU unit, was in that pilot. And we learned a lot through that. And I sort of transitioned into leading the work at the hospital level. I became partners and co-chairs with Dr. Lori Hamama, who is a practicing family physician. And she was sort of tapped to, hey, you're doing a lot of work in the med ed space. You should work with Kristi. She's doing work in the quality and like the hospital space with associates. So we led that system collaborative for several years and just really wanted to pull together all these pockets of work that was happening, right? There were a lot of people who were super passionate about resilience and well-being, and they were doing their own little things. And so we were like, how can we pull everybody together to sort of say, what are you working on and how can we work with you so that we're not duplicating efforts, so that we're pooling our resources. Through that, we started looking into evidence-based practice. What does the research show? What should we be focusing on? And we realized we actually did need some dedicated FTEs. So we wrote a business case in 2019. Our dream big, right? Like everybody's like, dream big. What would your ideal state be? And we were really like, oh, what would it be amazing if we got 0.7 FTE for a CWO? And then maybe 2 FTE to actually do the work, right? To actually do the programming work and what we needed. And so we put that in front of our leaders. Everybody's like, this sounds great. And what we came out of it with was a 0.7 for a senior medical director. So for Dr. Hamama. And that was in the fall of 2019. And then, as we all know, the world shifted on its axis in March of 2020. And what was, not to say like, yay, pandemic, right? But, like what was really great was we actually had already created a plan, right? Like we had done the research, we had looked and seen like, what do we really want to focus on? What do we need to focus on? And so we were able to pivot within 2 to 3 days of everything shutting down into standing up what we call the Resilience Operations Center, which was really how do we understand what the needs are of the front line and how do we rapidly deploy support to those that need it the most. So that's what we did for 3-4 years. I mean, it was just take it in. What can we get out? What can we take in? What can we get out? And now we've shifted into this more long-term planning. We have about 35 FTEs on our team. That includes our internal employee assistance program, our dedicated provider well-being team. We do a mindfulness program. And then we also have advisors who roll up through me that do that strategy and program development work.
Oh,
Wow, that is amazing.
Yeah. Well, and the other thing is the fact that you all started this work pre-pandemic, because what we're seeing is a lot of these programs have been implemented post-pandemic, not pre-pandemic, but it also takes me back to the National Academy of Medicine's work, which started 10 years ago. I know I attended a couple of meetings 10 years ago representing AACN when they started the collaborative looking at clinician well-being, which was way before it was a cool thing to worry about, I would say, for lack of technical terms, right? So you focus your program on the National Academy of Medicine's key focus areas for clinician well-being. So how do you describe those focus areas and how your program addresses those key recommendations?
Yeah. So you're exactly right. They published those guidelines, those recommendations in 2022 after years of work, right? And there were really 7 focus areas. A couple of them were focused on how do you create an environment where everyone can thrive, right? So there's a couple that relate to that. They also made sure to call out specifically in a focus area, incorporating diversity. There is an area that's dedicated to reducing policy and regulatory barriers that just make work so challenging for our clinicians. And then there's a call out for measuring the impact of the work and then doing more research into it. Ultimately, the goal is really to institutionalize well-being as a long-term value. That is the ideal state, right? Like the thing that we're driving towards with all these other focus areas. So we took 3 of those that we really felt we could tackle, like in the beginning, that felt that they were the most urgent to us, which was creating and sustaining a positive work and learning environment. The second was supporting mental health and reducing stigma. And then it was that third one of that long-term value, institutionalizing well-being as a long-term value. Some of the fear coming out of the pandemic, as they were saying, like, how are we helping to help teams recover? How are we building programs that do that? Was that this was going to be just a fly-by-night sort of thing, right? Like well-being was going to be like, oh, that's the thing of the moment. And then like, okay, now we don't want to talk about it anymore because you're reminding me that the pandemic existed, right? Like, so how are we making sure that this just becomes a part of our culture, a part of our fabric as an organization? So those are really the 3 areas that we're leaning heavily into now, pulling in pieces of those other ones, right? We work with our culture, engagement, and belonging team on the diversity piece. We are always measuring. I'm such a fan of data. I love data, right? So like, how are we making sure that this is actually having an impact on our people? So. that's how we are focusing on those.
Well, and that's so key in changing culture, is making sure it's a part of what we're a being versus a program, because nobody gets more irritated when we say we have to participate in this program and then all of a sudden it goes away.
Yes, exactly. Check the box and now we're done, right? Or yeah, that didn't actually have an impact.
I find this just like so fascinating. And I have actually two questions. One is how you got buy-in and support, because that is key. Because if you don't have that support and you don't have that buy-in, it's going to be really hard to launch a program, right, like this. So that's one question. And then I know that you're part of a fairly large system that has a mix of academic and community hospitals. So I'm curious, is the program different depending on which hospital it's in? So
Yeah.
which one you want?
Sure. I'll start with the buy-in, because you're absolutely right. Buy-in is so important to being able to get these programs up and off the ground. I will say the thing that we learned is that there are true believers everywhere, right? Believers that get it, that how absolutely foundational well-being is to being able to do anything related to our mission, right? Our mission to improve the health of those we serve, right? We can't do that if we are not well ourselves. And so you will always find those true believers throughout the organization. And so that's what we really did. We leaned into finding those believers who would support it. I talked about our original 0.7 FTE for our senior medical director, right? That was in the system quality department because our VP of quality believed it, right? Like believed it was important and valuable. And I would also say, don't underestimate the grassroots efforts and the importance of having the grassroots behind you, right? Every single person on my team is or was a practicing clinician. Like I said, our senior medical director still sees patients every Tuesday morning. I was a bedside nurse for decades, right? We have a speech therapist on our team, and it's through that of being able to understand where they are and to be able to say, this is important to us because we've been there. And having that grassroots be able to help support you, right? Because if I'm coming in and saying, I need you to do this 20-minute module on the LMS about your well-being or burnout, right? Like that's never going to work. It's never has worked. And so it has to truly be meaningful. And so that's important. And I think it was easier, like I said, during the pandemic because it was important and people saw that. And now it's how do we make sure that people continue to think it's important? How do we help them solve problems that they're having that they see are important right now? A big thing is like turnover, right? We know that in nursing, we have so many people retiring, so many people leaving the profession. That for HR, for our senior leaders, is a really, really big deal, right? How can we help them see the connection between well-being and burnout and turnover, right? So how can we help them solve the problems that they think are important right now? So that's one. The other question, exactly. We are currently sitting at 16 hospitals. We are in 55 of 88 counties in the state of Ohio. We cover everything from our capital, Columbus, which is where I live, all the way out to our small rural areas where we have an 8-bed safety net hospital. So you're exactly right. We are supporting people in acute care sites and ambulatory sites. We have over 300 ambulatory practices. We support associates. We support physicians. So yes, the diversity is out there. And what I will say is we know that there are systemic drivers of stress, things that impact all of us in healthcare, regardless of your role. And then there are local drivers, right? Whether that local is your care site, your hospital, or whether it's your team, everyone is going to be different. So we have to develop those programs that span the system, right, that people can dock into, and then help people figure out, how does this translate to my work environment, right? Like, how am I going to take this information or how am I going to figure out which program is going to work best, either for me as an individual or my team? And that's the hard part. Like, I love that I can sit here and say, like, we have 35 FTEs and we don't have enough. I mean, honestly, right? Like, to be able to do that local level work to really help them dig in and figure out wow, is this like a staffing workload issue? Do I need to figure out which medications are in which Pyxis so that I can move things around so that it makes more sense and I'm not, like how do we do that kind of work is really hard and time intensive. So you have to do it all.
Yeah, and that really takes me to our next question, because so much of what bothers clinicians, I'm trying to think of the right word, but bothers clinicians is this whole environmental aspect. So one thing that we have found is resilience has become an R word, because clinicians don't want to hear you need to become more resilient, go fix yourself, when part of what's driving them crazy is the work environment and those little, what I like to call, being from the Midwest, pebbles in your shoe that you get when you're walking down the creek, right?
Yep.
So how does your program really try to address those environmental aspects that really impact clinician well-being?
Yeah, that's such a great call out. And I agree. I usually, when I start like a presentation about like our programs or whatever, I'm always like, so here, who here hates the word resilience? Raise your hand. Who here hates the word burnout? Raise your hand, right? Because you're exactly right. They become bad words. And I think a lot of that is because we were basically like, just go home and take care of yourself, right? Like you need a bubble bath on a Sunday and you're going to come back and be fine. And like, what? No, like that doesn't help anybody. So self-care is important. Don't get me wrong. To clarify, but so really, a lot of it is leaning into things that already exist. Shared governance is a great example of that, right? Like what really helps people is when they have input into that decision making. And the front line, the people doing the work, they know, right? Like they know what the problems are, they know what the solutions are. And so how can we help leaders really value that and prioritize that in a way that helps them see that that is all related to well-being, right? Like that is all a part of it. We like to say that we're the voice at the table. So our goal as a team is to be at the table when decisions are being made that will ultimately impact, right? Like our frontline teams, and to just ask the question, so how is this going to impact everybody? Like, how is this going to like impact them? A great example, our largest hospital that has over 1,000 beds is going through a bunch of parking issues, right? Like as one does, right? When you're adding more beds and everything, and it's like, we do not have enough parking for our patients, let alone for our staff, right? And so they had this idea, like, well, let's just, park them like way down the road and like we'll shuttle people in. And what they were finding was that associates were late to work, right? And it was like, and so their initial response was, well, people just need to be on time, right? People just need to be on time. And if they're not going to be on time, well, maybe they need to leave earlier. And so it was our role as advocates to say, time out. What could potentially happen, right? Like we have a lot of moms, parents, right, who have to drop their kids off at a certain time. Like we have like literally the line was like 3 miles long to get into our parking lot. Like that's not on them, that's on us as an organization. So I think there's a lot there in terms of like really talking about how important it is that the organization is taking responsibility for that and finding ways to include people in the problem solving.
I really like that you called attention to having that voice in nursing, hence, of course, our podcast, Voices in Nursing. But that is the truth, right? We have to have a voice. We have to have a seat at the table. And I think that, I don't know if you had any advice for our listeners at all, but how do you help the organization? You can say all you want to say, but if nobody listens, it can be very detrimental and disheartening for the staff. And they said, you know what, nothing ever changes. We're not going to say anything anymore. And I think that is so. How do you help them from afar or give them advice?
Yeah, I feel that on such a deep level. I will say, when I was actually a bedside nurse, we went 3 years without a lunch break. And I just remember that, and I'm the rabble rouser that pulled the federal guidelines and walked into the manager's office and said, this is illegal because that's the way I am. But I would just say, we have a saying on my team, and it's just do the next right thing. And because it can be really, really hard when you're in that space and you're like, no one is hearing me, no one is listening to me. We felt that so hard, honestly, in 2019 when we took our business case and everybody's like, sounds great. And then you're like, and there was no and, right? It was just like that sort of like, okay, now we're done. And it is hard. You get tired. You get tired of being that voice, of always feeling like you have to be the one to push things. So lean into the people beside you, lean into like we also have, on our team, we're really good of like, you seem like you're flagging, you seem like you're tired, right? Like go ahead and take that step back. I think there's a whole story around like a flock of birds and how they fly in a V's, and then the leader will go back and someone will go forward. That's what we do, right? We do that so that we rest and we come back to it. It's the same with our work, our nursing, right? We need to rest and then come back to it, right? And so it's okay to take that break. But when you're passionate about something, when you know it's the right thing to do, take a rest and come back.
Very true. And if only we could get the nurses to give up their phones so they can actually take their break, right?
Take a break. I will actually challenge that. And I will say, if we had staffing at a level where they would fully take over our patient assignment and not be doubled up, I would guarantee you more nurses would take their lunch breaks. So
free of a phone.
That's right.
So my real question though is, what would some of the wellness programs that you have, which ones would you say have the most participation or engagement, or that the nurses really like?
Yeah. So we launched a dog therapy program specifically for our providers and associates just about a year ago. And oh man, everybody loves dogs. So they love them. We have so many amazing pictures. Everyone is always smiling when they have them. We had dogs in our hospitals for the longest time for our patients that came through volunteer services. These are for our people, right? Like this is for them. I think it's well, first of all, I love dogs too. So that's that. But the other thing is it's right there on the front line. It's so easily accessible, right? I don't have to schedule something, after work, or I don't have to take an hour to do something. Like it's just a few minutes. I can step away from my patients. I can love on this dog, decompress some, and go back. And so that is absolutely our number one program. Amazingly, we also have really good engagement in our peer support programs. So we have a specific peer support program. We have almost 800 people trained as peer supporters across our system. And I think that's because we know that healthcare is a team sport, right? Like we have to be there for each other. And that is also protective of our own well-being when we're supporting others. And then I was really surprised by this, but we launched a suicide prevention gatekeeper training program. It's called REACH. And it's all about training people to identify suicidality in our peers. So the people beside us, not our patients, but the nurse walking next to us, and being able and equipped and feeling ready to ask the question that you have to ask. Are you thinking of killing yourself? Which is a very hard question to ask. And then connecting them to the right resources. When we launched the program, we're the first healthcare system in the country to offer this. When we launched it, our goal was to have 75 gatekeepers trained. And in the first 2 months, we trained over 300. We now have over 700 gatekeepers trained, and we've actually know that we have saved 7 lives through the program. So I was surprised that would be a program that so many people would want to participate in, given the really difficult and challenging topic. And yet people are so committed to this. They're committed to their teams, to their colleagues, and to the organization as a whole.
Number one, that is incredible. And I think suicide is one thing that we know happens in healthcare workers, but we don't think about it. And to provide that training to, save one of our own is so incredibly valuable. You should all be commended for that work, because that's incredible. I think one thing I want to go back to, and you talked a little bit about this, but you talked about really involving frontline staff in helping to design some of these programs. So talk to us a little bit, because we know from our work in establishing and sustaining healthy work environments that the key to that is really that frontline personnel and getting their input. So how have you involved direct care staff, and how have they directly influenced some of the programs?
Yeah. I love that question because we are such believers in getting that voice from the front line. We're a lean organization, which means we rely on lean principles for process improvement. And one of their basic tenets is the people that do the work are the ones that are the experts, right? And they're the ones that know. I will give a specific, when we had the Resilience Operations Center during the pandemic, we actually were getting tons, we were flooded with ideas and requests and all of this stuff. And they came from all different sources. And so we actually put together a specific process. I'm also a process girl. So a specific process for doing that intake. And the very first question on that forum was, is this request coming from the front line? Because we would have leaders, very well-intentioned, who would throw out some ideas that were a little skeptical. One great example that I'll just share. We had a leader, a pretty senior leader, who was like, here is an idea. We know that it's very stressful. We want them to be taking, even micro breaks, like as they're like taking care of like whatever. What if we announce overhead every hour, the next minute is a mindfulness minute. We want you to spend the next minute mindfully. And I was just like, oh, wow. You almost don't even know how to like respond to that. You're like, that is so well-intentioned. And could you imagine a nurse gowned head to toe in isolation gear doing compressions on her patient or his patient, and they hear overhead, take the next minute to be I was just like, oh, okay, so we have some work to do. So super important. The second question on there, if you answered no to that question, no, this is not coming from the front line. The second thing was, you need to go and vet this with 3 frontline associates and then come back to us. Because so we built it into the process. If you're just throwing things out there and it's not actually going to be meaningful, then no, we're not doing that. We continue to do that today. We are huge on continuous process improvement. So we are always seeking input from the people that are engaging in our programs, whether that's through surveys or just like talking to people afterwards. We have a really incredible critical incident response program. And we actually, when we put together all of the different work teams to design and create that, it was primarily frontline teams and staff. I can't design a process for how you're going to notify us when a distressing event occurs, because I don't know your workflow. I don't know who will be there, right? Like, so I can't just say like, well, you'll have the chaplain call or you'll have the nurse administrator call. Guess what? Some of our hospitals don't have nurse administrators. So it was super important that as we were creating these things, that we had their input and they had a voice at the table. And that they continue to have that opportunity. So, and they could modify it. That's the other thing. We always want people to modify it to make it work for wherever they are and whatever their current processes are.
That's amazing. I commend you for everything. This program sounds absolutely amazing. And I truly believe that the nurses are really part of the decision making in this organization, and that's great. And I know you mentioned how much you love data, so I would assume that you are tracking the successes of the program. So what metrics are you looking at to evaluate the effectiveness of these programs?
Well, we look a lot at our leading indicators. So we look at engagements, lives touched, however you want to say that. So participation in our programs. For example, our health system is incredibly supportive of mental health. And this year we went up to 12 no-cost counseling sessions through our quote unquote EAP, which is actually through our wellbeing center. So our EAP utilization rate is actually well above national benchmark. So we're sitting between 10 and 11%, whereas national benchmark is 5 to 7%. And we do a lot of work to that. So we definitely look at engagement, participation, and we are looking at things that I like to call proxy measures of well-being. So We do utilize the well-being index, which is a validated tool for measuring well-being. It just doesn't have a lot of participation. Like it's hard to get people to open another app. I hate all the apps on my phone, by the way. Open another app, do another thing, right? So how can we really understand the well-being of our teams without having them do one more thing, right? So we look at things, like I said, what I call proxy measures, things like turnover, things like our customer experience scores, our patient safety events, our quality outcomes, all of those, again, because they're all so directly tied to well-being, we can look at those and say, is this team doing better or worse, right? Like it is like compared to last year, we've done some things, we've supported this team, we've done a couple of interventions. How are they doing now? What are we seeing on the backside of that? So that's really where we put our measurement into, simply again, because we really don't want to overburden people with having to do, like if I have to take one more survey, honestly, I just can't do it.
Yeah, I think most of our staff are survey fatigued at this point. So
Yes,
I
right.
appreciate that. So I want to flip us a little bit into a new direction and something that's here to stay, and that's AI. So what do you see as the future, and how are you planning to integrate AI into the well-being work that you're doing?
Yeah. Okay, I have never in my life figured out ChatGPT yet, but it is on my list of things to do to figure out how to use AI. But we actually, I feel like OhioHealth was relatively at the forefront. Whatever. We've done a pilot on the ambient AI, so the ambient listening AI with our physicians. It was such a great partnership to work with them because we were able to include a well-being question on the pre and post survey to be able to demonstrate that AI is actually improving well-being. And the really cool thing is we didn't just send it to the physicians who were in the pilot, we sent it to their partners, their spouses as well. So we asked them, how engaged are they at home? How has it improved? And we saw a dramatic improvement, right? A dramatic improvement, both in self-reported and partner spouse reported well-being through the use of that ambient listening AI, which I hope, just in case people don't know, it used primarily in primary care, but it listens to the entire encounter, and then it types up notes. It can send orders. Literally, they're like, okay, we're going to draw a CDC and a Chem7, right? And it just it'll automatically do it. And through Epic, which is what we have, it sends the orders. It's really amazing. Saves tons of time. So I think, and I think there is also opportunity in the nursing space for tools like that, especially for that ambient listening AI sort of thing. At the recent National Academy of Medicine meeting in December that was out in San Diego, the whole 2 days was around AI. And I heard some things that were fascinating, that helping really identify patients that might be deteriorating, that it can do that 12 hours sooner than what we currently have now. It could be something where you're doing your head to toe assessment and you're just saying, okay, normal reflexes and and it just documents it and it puts it into the chart for you. So I think there's ample opportunity to help us really to leverage that in a way to take away some of that monotonous, right, administrative burden that we have, and help us really get back to connecting with our patients. I will also say we are using Copilot. We're in a pilot for Copilot right now, which is more on the administrative side, for people like me that work from home in my office, and just being able to document, do meeting notes or all of that stuff. And so I think all of that is going to be helpful, because the more time we free up from people, the more they're able to, and it doesn't mean giving them more work. It means, can we really do the quality work and the connection with other human beings? How do we let AI do the stuff that whatever, so that we can really start to lean into connecting with other humans? So that's what I'm really, really excited about.
Yeah, and I think the one important thing that we have to keep in mind is, as we develop these AI tools, that we involve the frontline staff in that.
Yes. Yes.
Because, to your earlier example, we may think something's helpful, and then when it gets developed and put out there, it's not actually helpful. So
Right.
I think that's one thing we have to keep in mind. And And for our listeners, if you're intrigued about patient deterioration and AI, we actually have a podcast with Sarah Rosati, who has done instrumental work, and she's a nurse who's done instrumental work in developing these patient deterioration tools. So I would invite you to tune into that episode if you want to learn more about that.
I have to admit, the thought of being able to do an assessment and just say it out loud and have it charted, I think would be so appealing to every nurse on this planet. So
Yeah.
hopefully, with any luck, things will go in that direction. But Kristi, I just want to say thank you so much for sharing your passion, your expertise with this work. It's really inspiring, and it's obviously so important for the physical, the mental health of nurses, the job satisfaction, and then the retention especially. And I really think that there's so many organizations and even individual units, if the organization as a whole maybe can't support it, that could learn from what you've implemented. So what I would like to ask is, if you had to share a takeaway for our listeners, what would it be?
Start small. Start small. I love, Vicki, how you said pebble in your shoe. Start small. This for us has been a multi-year journey, and we didn't get here overnight. So start where you can with what you can, right? Find your people, find the people doing similar work, find the people who are passionate about this, and just do what you can, right? As best you can. Lean into the evidence. The National Academy of Medicine has tons of stuff out there for you. Find your resources, and just keep doing it, because it is important and you are important and this work is important.
Well, thank you so much. And thank you to our listeners. In conclusion, today we would love to hear your feedback on this episode and any ideas you have for future episodes at podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's online course, Essentials of Critical Care Orientation, or ECHO, providing modular, interactive, case-based orientation for ICU or PCU patient care, with information available at www.aacn.org/orientationcc.